This is a very nice topic that was given to me, integrating hemodynamics in high-risk PCI, because most of the data that we have is in either preemptive or cardiogenic shock, and so these are early on and very interesting to learn about it as well. So obviously there are no disclosures. So this is, let's start with the case history. 72-year-old woman with past medical history of hypertension, diabetes, hyperlipidemia, breast cancer, surgery, and she was admitted to the satellite hospital for evaluation of revascularization and presented with a sudden onset of shortness of breath for 1 hour and used rescue inhalers without relief. Blood pressure 149/94, respiratory rate is 22, heart rate is 92, and saturation 97%. And troponins peaked actually at around 16,000. And as you can see, the creatinine is okay, 0.86, and hyperglycemia and hyponatremia. So this is the admission ECG, which shows actually that the patient has some inferior T wave inversions as well as lateral ST depressions, and echocardiogram was done, which actually shows that there is some wall motion abnormalities in the anterior wall region, and ejection fraction was read at as around 40%. And so then a diagnostic angio, this is what it is. Actually you can see that there is a RV marginal ostial, or just prior to the takeoff RV marginal, there is a lesion in the right coronary artery, and heavily calcified circumflex artery, as you can see, and also calcified LAD, that very heavily calcified vessels. So these are the pictures. Now what do we do in this patient? This is a typical or high risk patient, and how would you approach? Obviously we do heart team approach, and the CT surgery consult was done, and patient was turned down for bypass due to multiple comorbidities, including the breast cancers, radiation, and mastectomy and all that. Okay. So what do we do in this patient? So this patient at our clinical center, we are part of the Protect 4 clinical trial, and so she was enrolled in the Protect 4. And so if you look at Protect flow, this is a study flow. Patients with multivessel coronary artery disease, which she meets, more than 2 lesions in 2 arteries, or and EF less than 40%. Actually now we are finished 40%, 35%. Now we are actually only enrolling patients less than 25%, and STS score of more than 5, and prohibitive risk. The surgeon has to decline surgery in these patients before considering for enrollment in the clinical trial. And so these patients either get into a complete revascularization with an Impella, or complete revascularization without planned hemodynamic support. It could be standard of care, whether you want to put a balloon pump, but you have to disclose everything up front. You have to have a plan. You say that I'm going to use a balloon pump, or I don't want to use a balloon pump, which lesion you're going to do first, when you're going to, if you want to stage it, you can. And so it's all, you have to mention all that ahead of time. And primary endpoint is composite death, stroke, non-procedural MI, repeat revascularization at 90 days, and several other points. So the patient actually is part of the thing. We also have to disclose whether your center wants to be part of the right heart catheterization or not. So this is actually the trial which will show us how to integrate hemodynamics in high risk PCI, and this will become hopefully a standard of care. So we are excited about actually being in this study, as well as actually saying that we will do this sub-study of right heart catheterization. And so this patient underwent right heart catheterization, which essentially is normal, but as Dr. Marty Leon said, that most of these patients actually now upfront aggressive medical therapy has to be reinstituted. Patient has to be seen by a heart failure doctor, started on the 4 pillars of therapy for heart failure, including beta blockers, Entresto, and spironolactone, and SGLT2 inhibitors. And so that's the reason that by the time the patient came to the lab after a couple of days, it looks very good. Then obviously all the standard of ultrasound guided micropuncture access of femoral artery has to be obtained, and so you know that the femoral arterial size has to be large enough and to be randomized which way the patient is going to go, whether Impella or not. And so, and we did a relook again, and the patient's EDP is 7. Patient was randomized to actually no standard of care, which is no Impella. And if I get into trouble with this patient, the only escalation could be balloon pump or after balloon pump and ECMO. Whereas if you are an impeller arm, you can go from impeller to a CP to a 5.5. Okay, so we can't cross over. We have to be careful about that as well. So this patient, based on the EDP of 7 and wedge of 8 or so, I was very comfortable tackling this patient, but obviously there is always a chance of no reflow and ischemia that can happen in these patients. So you have to be careful and have a strategy of escalation to an ECMO. You might have to inform your ECMO team. In our center, the surgeons do the ECMO, so we also have them informed at least. So this patient had a rotational atherectomy and I think cutting balloon after that, and then a stent was placed, and so patient did actually have slow flow, which improved with some adenosine, and then LAD was crossed with a turnpike LP and a run through wire, and again exchange for rotafloppy, and then after rotational atherectomy and multiple another stent. There's a good flow in both the vessels, and we achieved that. So, so what does MCS for high-risk PCI? What are the potential benefits? I think reduced procedural complications, improved early outcomes, and it can improve probably late outcomes, and decrease MACE, heart failure, and reduce hospitalization and increased quality of life. Probably it also can have some renal protective effects, we don't know. So this is what this is being evaluated in PROTECT 4. All these 4 things will be looking at and looked at. The pulmonary artery catheter, I think I don't have to go because Vishal has actually covered very nicely. And there's another group of people who are actually high risk or at high risk but not in cardiogenic shock, are acute anterior wall myocardial infarction, where a door-to unload study is being done. We were part of that, and not really anymore, but prior to COVID, we were enrolling patients in the door-to unload DTU STEMI trial. So those patients in EF less than 35% and obviously anterior wall MIs, and prior to getting a revascularization, they can have an impeller placed or just standard of care, and whether unloading of that patient is going to benefit anything. So these, in my patient, the PAPI is more than 4, so it is normal, and everything looked actually very good in these patients, in my patients. So, but right heart catheterization will allow you to decide whether it is right RV failure or LV failure, and what can you do about these patients. So I think this I'll skip. So these are the patients that we are talking about in the high risk PCI, people with the surgical patient comorbidities, such as my patient with the diabetes and ACS, and also had not a good chest for surgery. Complex coronary artery disease, and there was no hemodynamic compromise in my patient, except that the ejection fraction is less than 40% or 35% is also allowed. Okay. So right heart is important in weaning as well as escalation. So the clinical trial in PROTECT 4, actually if you're randomized to standard of care, it only needs 2 right heart cath measurements, just one before and one after the PCI. So that's actually very nice and easy. If the patient was randomized to impeller arm, you have to take 5 right heart catheterization at every step. So if the patient's saturation, which was in my patient was 63%, if the saturation falls, or if the blood pressure falls and PA with systolic pressure, some PA mean pressure drops, we have to wait on the device until it comes back up to at least within the range of 20%. So these data, which we have never had an idea of how to integrate into our high-risk PCI patients. So just putting a device in, doing an impeller, which is expensive, and doing a PCI and taking out the device is not the answer. You have to look at the PA saturation, you have to look at the pressures. If they don't recover, keep the device in, send the patient to ICU, and even after you can remove it later on. So it's not that is actually where the whole idea of actually integrating right heart cath is coming from in these patients, and where we can learn from the others. So there's also a weaning protocol, and here is similar to other, this is one of the tied weaning protocol. You look at the transthoracic echo and the full impella unloading if the patient goes to impella, and you reduce the P levels on the pump levels on the impella, and you can do a dobutamine stress echo, or you can do exercise testing via hand grip. Or actually in this as we mentioned, integrating right heart cath pressures as well as the PA saturation is another way in a Protect 4 to look at it. But the other one is actually just looking at before weaning and after multivessel rotational atherectomy, if the EF is around 20% and you did a successful PCI, look for stable mean arterial pressures and end diastolic pressures. So these are all very clearly given here, and end diastolic pressure can be given on the impella device itself, and assess the native heart recovery by an echocardiogram on looking at the cardiac output as well. And as you reduce the impella flows, and your native cardiac output should be maintained or at least slightly going up and maintaining the overall cardiac output. That's the most important one to wean the device. So here again, as you see, on the yellow one, it should be coming down, and which is the impella flows, and at the same time EDP should remain the same and should not go up at all. And if it goes up remarkably high, then you probably have to go back on the impella, and the mean aortic pressures should be stable at a P4 level. That actually indicates that this patient is probably can be weaned down slowly. And this is a similar, actually cardiac power output remains at the 0.6, and cardiac output is at 3.7 liters, which actually helps us to do that. So, and if you have hypotension, again, please do not wean quickly, maintain the impella, and if no hypotension, you can come down to P2, and again, stable mean arterial pressure and end diastolic pressures are the most important points in favor of weaning the impella out. I think use of PA catheters in acute patients, as we know, but in high risk PA patients, it might also help with the weaning or escalation of the devices. We don't have strong data to support that yet, but that's what we are collecting now. And use of a PA catheter may guide optimization of therapy, particularly during impella or other mechanical circulatory support, to restore normal hemodynamics and physiology. So you can give more fluid challenges, inotropes, which if it might help, and hemodynamics are even more complex during obviously ECMO and biventricular support, and extra care during prolonged PA catheter usage is recommended because it can lead to infection, vascular damage and thrombus. Thank you very much.